Good evening. I think we're ready to get started. Thank you so much for joining us today. By way of introduction, my name is Ileana Oris Valiente. I have the pleasure of sitting on the board of directors here at Sunnybrook Health Sciences Center. It's my pleasure to welcome you to this month's speaker series. The subject for today is very timely, and it's perinatal mental health, understanding depression and anxiety during pregnancy and postpartum. Before we begin, I would like to take this opportunity to say that we at Sunnybrook, our mission is to care for our patients and their families when it matters the most. Sunnybrook also cares about our collective responsibility to achieve reconciliation with Indigenous peoples who have lived on this land for generation upon generation. So we acknowledge that our campuses are located on the treaty territory of the Mississaugas of the Credit First Nation and the ancestral and traditional lands of the Anishinaabe, the Haudenosaunee, the Ojibwe, Chippewa, and Huron-Wendat nations. Today, this land is home to many First Nations, Inuit, Métis, and urban Indigenous people from across Turtle Island. We value their contributions, past and present, and we are grateful to work in the community on this territory. So, why are we discussing the topic of perinatal mental health? Well, earlier this month, actually on October 10th, we celebrated World Mental Health Day, and it's a good time to raise awareness about mental health in the context of overall well-being. Here at Sunnybrook, we believe that every day is a good day to expand our knowledge and work towards improving mental health care. Next year, we look forward to opening the Gary Hurwitz Brain Sciences Center, and it's going to be a collaborative space that will enable teams to provide leading edge mental health care and continue to invent the future of healthcare specifically for mental health. Sunnybrook is also an important leader in the prenatal health division. We have our program, the Dan Women and Babies program. We also have delivery and post-birth care and gynecological care. We specialize in caring for the tiniest and the sickest babies, as well as people who have high-risk pregnancies. Our experts from the Hurwitz Brain Sciences program and the Dan Women and Babies program, you are going to be hearing from tonight, they know that perinatal mental health is hugely important, and it goes hand in hand with overall population mental health. So for many patients, pregnancy and postpartum bring a series of unique challenges and requiring special care that's unique. And that is what we are going to be discussing this evening. Tonight's discussion is going to try to answer a handful of key questions, including how many people and how common postpartum depression and anxiety is, how can it affect the physical health of the parent and the child, and what the treatments and the available options happen to be. We have a dynamic duo teed up for us this evening, so we're very fortunate to have them here to tackle our questions. We're fortunate to have Dr. Janet Bodley, who will be moderating this evening's event. Dr. Bodley is an obstetrician and a gynecologist in chief at Sunnybrook. She is also the chief of the Dan Women and Babies program. Dr. Bodley has worked at Sunnybrook since 2003, where she has prioritized wellness as well as many other things as part of her administrative and her leadership duties. She's also an associate professor in the Department of Obstetrics and Gynecology at the University of Toronto, and is also the associate program director for the department. So she's very busy, and we're glad to have her here this evening. This is just a snapshot of Dr. Bodley's biography. We are in great hands today with her as the moderator for the discussion. So Janet, with that, thank you so much for being here. I'm going to pass the floor and the virtual microphone to you to kick us off this evening.
Thank you so much, Ileana. And good evening to all of you who are joining us to learn about perinatal mental health Understanding Depression and Anxiety During Pregnancy and Postpartum. As you will hear shortly, Sunnybrook has deep expertise caring for people who are pregnant, as well as people experiencing mental health concerns. One of the many things our Dan Women and Babies program specializes in is patient care for the period around the time of pregnancy and birth, as well as the care of newborn babies. And Sunnybrook's Hurwitz Brain Sciences program is dedicated to excellent clinical care and pioneering investigation of some of the most challenging brain conditions, including mood and anxiety disorders. Tonight, we are very lucky to have speakers from each of these care programs to share their insights with us. Dr. Sophie Gregoriadis will start things off by outlining the prevalence of depression and anxiety during pregnancy and postpartum, as well as new research findings and treatments available. And then Dr. Anne Burndell will share some of her learnings and insights on the impact of depression and anxiety on maternal and fetal health, including for people with physical disabilities. As always, we'll set aside some time at the end for you to ask our speakers your questions. Thank you to everyone who has already submitted a question online. Please feel free to also send your questions through this webpage while the presentations are happening. We may not be able to get to every question, but we will do our best in the time we have available. So, to begin the lectures, I'd like to introduce our first speaker. Dr. Sophie Gregoriadis is a psychiatrist and head of the Women's Mood and Anxiety Clinic, Reproductive Transitions, in the Department of Psychiatry at Sunnybrook. The clinic focuses on the assessment and treatment of perinatal mood and anxiety disorders. Dr. Gregoriadis is also a scientist with the Hurwitz Brain Sciences program at the Sunnybrook Research Institute, where she has been involved in several clinical trials. Her clinical research focuses on the treatment of mood and anxiety disorders in women across the reproductive life stages and interventions, including medications, talk therapies, or other non-medicine solutions. In addition, Dr. Gregoriadis is a professor in the Department of Psychiatry at the University of Toronto. She is actively involved in teaching at all levels, including continuing medical education. As you can tell, we are very fortunate to have her here this evening to talk about this important topic. Sophie, thank you for joining the panel, and I'll send it over to you.
Thank you so much, Dr. Bodley, for that wonderful introduction. It's always uncomfortable listening to people talking about you. I always just say, Sophie will talk a little bit about perinatal mental health. But thank you so much. And thank you so much, Ileana, for the introduction, and to our Sunnybrook team for arranging this evening tonight. I will try to convey to you the little that we know about perinatal mental health, but first I'm going to try to share my slides. And hopefully we will not have any technical issues. Maybe I can talk to Janet. Janet, are my slides sharing? I can't tell.
They are not.
They are not. Okay, well, let's see.
Now you're good.
Now I'm good. I'm not sure if that's me or if that's our audiovisual team. Okay.
Can you change the slide?
Yes.
Good to go.
Isn't that always the case? Okay. So I can't control the slides, but our AV department will be able to do that. Thank you so much. All right. At the end of this presentation, we're going to help you understand the rates of anxiety and depression in the perinatal period. And the perinatal period encompasses both depression and, both pregnancy and the postpartum periods. We're going to appreciate some treatment options, and we're going to become more aware of some exciting opportunities. Next slide. This talk is about the prevalence of perinatal mental disorders. And I'm going to talk a little bit about what we know in terms of how common these treatments are, a little bit about depression, and some innovative treatments. Now, Dr. Burndell and I decided to let me do the technical stuff, if you will, and she's going to present a patient case and talk about, excuse me, how depression and anxiety presents. So, I wanted to give you an overview, though, before I start talking about more nitty-gritty things, that perinatal mental health encompasses all of psychiatry, basically. So any disorder that can present at any life stage could also present during pregnancy and postpartum. So things like, eating disorders, mood disorders, substance use, anxiety disorders, as you can see up on the slide, a big gamut of problems. The most common ones are mood and anxiety disorders. So I'm going to be talking about those in a little bit more detail. Next slide. Let's look at the world stage, maternal mental health. Worldwide, believe it or not, approximately 10% of pregnant women and 13% of postpartum women experience mental illness. Those rates are quite high. Depression is amongst the most common. In developing countries, the rates are even higher, close to 16% during pregnancy and 20% postpartum. So this is not a North American problem. This is not a Canada problem. This is a world problem. Next slide. Perinatal mental disorders affect about 20% overall. If you look at the number of women in Ontario, so what I tried to do is make it understandable for most people. So we just talk about percentages. It's hard to put it into everyday understanding. So if you look at Ontario, this translates to about 28,000 women in Ontario. And in Toronto, we have about 31,000 births per year. Now, this can be a little bit higher, a little bit lower, depending on the year. But overall, that means there's over 6,000 women at risk yearly. That's a lot of women. A lot of people. Ontario spends about 20 million annually on complications of untreated and discontinued treatment of perinatal depression or prenatal depression. And so that things like, preterm birth, low birth weight infants, as well as other mental health problems. Now, we actually think that this number is probably lower than what's estimated because we can't capture some of the consequences of the effects of mental illness. Next slide. These disorders, unfortunately, continue to give. So the persistence of symptoms beyond the first year is not uncommon. Mothers have been found to have depressive symptoms at 4-year follow-up or higher than at 12 months. 1 in 11 continue to experience symptoms into the perinatal period to beyond the perinatal period to 4 years postpartum. And some continue to experience symptoms 6 to 7 years postpartum. Now, why am I telling you this? Well, because it's very important that we try to catch these women as early as we possibly can to relieve their suffering and help them enjoy the life that they want. Next slide. Now let's look at the overall prevalence of perinatal problems in terms of mood and anxiety. If you look at depressive disorders, it could be anywhere between 9 to 13%. So that means like depression and pregnancy and postpartum. Now, some of these numbers differ depending on how the study has been done. Okay, so keep in mind, there's always a range. Generalized anxiety, which is a part or is a type of an anxiety disorder, we think is more common in the postpartum than at other times of the life cycle. Panic disorder is also something that can occur up to about 2%. Obsessive compulsive disorder up to about 4%. And we think that there's a higher prevalence in the postpartum. And then, of course, PTSD is also something that we see. So depressive disorders, anxiety disorders, non-psychotic mental disorders are very common in pregnancy and the postpartum period, and they're amongst the commonest morbidities. In terms of the kinds of disturbance that we see in the postpartum, like I said, Dr. Burndell will talk more about how these people can present, but we know that postpartum blues affects up to about 85% of new moms, postpartum depression about 13%, and postpartum psychosis, which is a psychotic episode after the birth of a baby, is fairly rare, 1 to 2 per 1,000. And thank goodness, because that's a psychiatric emergency. Next slide. Now, some people ask me, why is this happening to me? Why me? Well, unfortunately, it's a very difficult question to answer, but we like to look at a broad perspective. So we look at biological factors, psychological factors, and environmental factors in trying to understand what may be a contributing factor or a causal factor. So in terms of biology, we know that psychiatric disorders tend to cluster in families. So if there's a mental health history there, we think that's important, both in terms of the person having a mental health history, as well as a family mental health history. So that speaks to genetic predisposition. Physical health is also important. We know that people that have had physical problems, so that could also be an issue. Hormonal, immunologic, or neurological problems. So, if there's any issue in those particular areas. Sleep disturbance, substance use disorders, we know that those are important risk factors. Now, please don't take this as exhaustive, but these are the main biological factors, with past history being the most important. In terms of psychological factors, we know that age can be important. So adolescent patients are at higher risk. If there's things like unemployment or low socioeconomic status, education levels, poor social supports, relationship quality, we know that's very, very important. Isolation and poor coping skills, among others. In terms of environmental factors, we know that people that have had traumatic upbringings are also at risk. Intimate partner violence is also a risk factor, and I'm going to talk a little bit more about that in a little bit. Cultural expectations. We did a study a while back looking at cultural rituals in the postpartum, and we found that there are certain elements that are more common than others in women that have had postpartum depression or that have postpartum depression. Complications, traumatic birth, issues with the baby needing an ICU admission, breastfeeding difficulties. Oh my goodness, that's something that I see very frequently. And a dysregulated infant. And like I said, these are the main factors, but not exhaustive. Next slide. Now, Dr. Ann Burndell will talk more about this, like I've said, but I just wanted to quickly talk about some of the main features. We know that people with depression don't have an interest in the things that they used to like to do. Their mood may be low, but it may not necessarily feel low. They may have sleep difficulties even when the baby sleeps. That's actually a key question. Are you able to sleep when the baby sleeps? They may have anxiety about baby and baby care activities. They may be reluctant to discuss symptoms with us, and they're sensitive to societal expectations. And by definition, the symptoms have to last for more than 2 weeks in order for us to think that this is a clinical depression. And I'm going to talk more about this in just a few minutes, but there's a risk of suicide and a risk of infant neglect. And in the worst case scenario, they can also develop psychotic features, and then there's a bigger risk of harm to self or baby. Next slide. Features of perinatal anxiety. Boy, I hear constantly about these recurring thoughts constantly going through their head. My patients will say they worry about the fetus or the baby. They can also have panic attack symptoms. Physically, they'll report more nausea and vomiting during the pregnancy, but like I said, we'll hear more about that. They certainly cope much poorer than they want to, and they may miss a lot of work or miss expectations of themselves in terms of their social responsibilities. They might report anxiety about not feeling movement or maybe feeling too much. And of course, these symptoms interfere with what the person needs to do on a daily basis. Next slide. Maternal suicide is one of the tragic consequences. A group of us looked at this issue a couple of years back, and we looked at what is the rate of death by suicide in Ontario. And we looked at administrative data over about a 14 or 15-year period. And we surprisingly found that suicide accounted for 1 in 19 maternal deaths. That is a high number. The average time that a woman died by suicide was about 5 months in pregnancy and about 7 months postpartum. And most of them, like I said, had a mood or anxiety disorder rather than a psychotic disorder. Infanticide is also another tragic consequences. This is where the mom kills her baby. It's oftentimes because of unrecognized or untreated postpartum mental illness. Up to about 30% of moms who kill their baby also commit suicide. Infanticide is seen in moms who are a heterogeneous group. So there could be a number of different factors, but acute psychosis after childbirth is one of them. And we think that the risk is about 4%. So 4% of moms who have a postpartum psychosis may end with this tragic outcome. Next slide. Like I said earlier, intimate partner violence is associated with perinatal mental health. We know that intimate partner violence is 4 times more likely in women that report depressive symptoms in pregnancy, 10 times more likely when the person reports anxiety symptoms in pregnancy. We know that 2/5 of women with depressive symptoms in the first year postpartum have experienced intimate partner violence. So we ask about how things are with one's partner. It's a very important factor to make sure we understand. Now, contrary to what we've talked about before in terms of postpartum depression for moms, these disorders or psychiatric disorders can also occur in fathers, and we're paying more attention to this. Now, what are some of the possible contexts for this? Well, fatherhood is supposed to be a time of joy, just like motherhood, supposedly. But if you look at the role, it can be quite demanding. There could be challenges in the relationship. In terms of identity, there might be some issues. Fatigue is certainly very, very common after having a baby. So we know that mood and anxiety disorders are also more common in fathers, but unfortunately, still poorly understood. But this is an area that we are actively working on. Let's get to treatment. So these disorders are very treatable. We like to start with a biopsychosocial approach, meaning a very broad approach where we try to look at the risk factors that I've already talked about. It's hard for me not to talk without moving my hands and try to keep them down. So we look at risk factors taking a large approach, biopsychosocial. We also do treatment in the same way. And we like to use a stepped care approach, meaning we try less invasive to more involved, more difficult treatment later on. So outpatient also to inpatient. First, we talk about depression. We talk about what this period is like, what you can expect. So we talk about the illness and what to expect in pregnancy and postpartum. And then, of course, what can be within the realm of what we see a lot of and what is in the realm of what we're more concerned about. And then, of course, when we're talking about treatment, we talk about the kinds of treatment that have, less risk to a little bit more risk. Psychotherapy is always something that we start off with. So individual psychotherapy has evidence that it works to treat depressive disorders and anxiety disorders. We also use group therapies. That's a good, efficient way of using our resources. And it also gets to social support, which is an important factor where moms get to sit together and share their experiences and help one another. Other psychosocial treatments are also important, and we try, and I'll talk about that in just a second. And then later down the realm is antidepressant medication and then hospitalization. And we take a risk benefit with every approach. Psychosocial interventions can include things like exercise, self-care, make sure that you go to sleep at the same time every night and you get adequate sleep. You eat well, you take care of yourself. We talk about breastfeeding and the kinds of things that they can expect. We talk about the importance of support and making sure that they get that from friends and family. If that's not possible, we may talk about hiring help if that is possible. Mindfulness approaches are also very effective. Mindfulness, like I said, in nutritional supplements, we talk about fish oil, light therapy, yoga, massage, acupuncture, as you can see. A wide gamut. Next slide. We try to prevent perinatal depression or perinatal anxiety issues as much as possible. And there is some evidence that counseling can be very helpful. But as you can see up on your slide, there's other issues that we're also looking into, and there is some support for those as well. But the most support is for counseling or talk therapy at this time. Next slide. And now at our clinic, what do we do? So we are the mood and anxiety clinic, reproductive transitions. We do assessments and then, of course, treatment. And we use the gamut of treatments from psychoeducation to psychotherapy to pharmacotherapy and more. And of course, we also do research. And we work with all the perinatal programs across the city. I shouldn't say all, but we work with other perinatal programs across the city. Next slide. I want to tell you about 2 exciting treatments that we've looked at recently and are continuing to look at. You need to push again for my splash part of my slide. Next slide. There we go. I had some animations there. Next slide. So let me tell you about TAPS. This is a study looking into treatment for anxiety in pregnancy. What we did is we took a mindfulness approach and we adapted it to pregnancy specifically. And we evaluated it to see if we can deliver it in a group format online. And then, so in that way, women can, or patients can stay home and receive the treatment at home. And the beauty of this treatment is that it's rapid. Within 5 sessions or 1 month, we did the treatment for the individual patients. And we're at the stage now, we're evaluating the data, so we want to see how good this treatment fares. Next slide. Where we're actively recruiting is another treatment for depression in pregnancy, and it's called transcranial direct current stimulation for depression in pregnancy. TDCS, or short for transcranial direct current stimulation, is a little device, and it's a non-drug treatment approved by Health Canada for the treatment of depression. And what we're trying to do is evaluate this treatment for pregnancy. As I said when I was talking about depression treatment, we start from the less involved to the little bit more involved. And this is one of the treatments that's more involved. So for women that we think they would benefit from medication, but the woman or person does not want to take medication in pregnancy for a variety of reasons, this may be a good alternative. And if we can show that it is helpful, it'll actually be revolutionary, because this is a treatment that you can do at home with minimal, if any, side effects. So we're currently recruiting for this. The sites are Sunnybrook and Women's College, and it's a collaborative project between ourselves as well as CAMH. Now, I've talked about some pretty heavy things tonight, and for those of you who want some support, we've included this slide, and the link is the active link for these resources. So if you want more information about where you can get some help, please go to our website for those resources. Next slide. Thank you so much. I know I went through a whirlwind of information in a very short period of time, but I wanted to give you an overview. And now Anne's going to talk more about specifics and how her patients present, and then they send to us.
Thank you so much, Dr. Gregoriadis. That was excellent. Before we continue, just a reminder to everyone tuning in to please send us your questions online if you have any. We are keeping track of those, and we will have some time shortly to start to go through some of those. I would now like to introduce our next speaker, Dr. Anne Burndell. Dr. Burndell is a physician and maternal fetal medicine specialist at Sunnybrook. She is also the innovator and medical director of the Accessible Care Pregnancy Clinic, the first clinic of its kind in Canada to provide pregnancy and birth care to people with physical disabilities. She's also an associate scientist with the DAN Women and Babies Research Program at the Sunnybrook Research Institute. Dr. Burndell focuses on the care of high-risk pregnancies, including pregnancies following stillbirth or neonatal death, and is recognized as an expert in the pregnancy care of people with physical disabilities. In addition, and if that wasn't already enough, Dr. Burndell is an associate professor in the Department of Obstetrics and Gynecology at the University of Toronto. We are so glad she is here this evening to share her expertise and address some of the impacts mood disorders can have on maternal and fetal health. Without further ado, I'll pass the microphone over to Dr. Burndell.
Thank you so much for that nice introduction, and I'm very, very happy to be with these two other experts here today. I know that we already heard a little bit about what depression, anxiety, depression in pregnancy can present as, what some of the risk factors are. But I'm hoping that today I can talk to you a little bit about how that might look from a clinical perspective, or how someone might be experiencing it from their perspective. And the slides are moving forward. You can have a look there. It's working? Yes? Okay, excellent. So at the end of this presentation, I'm hoping that people here can understand what depression anxiety looks like during pregnancy and after birth. I want to talk about how they impact the health of the person who is pregnant and their baby, and then talk a little bit about options for supportive care for people who might be particularly at risk for depression anxiety, including those who have a history of stillbirth or traumatic birth and disabilities. So what does this look like during pregnancy? And one of the things that is so important to remember is that I think there are few life changes that anyone is going to go through that's any bigger than having a baby. So the change in of itself encompasses every aspect of your life. It is a major life event. But during pregnancy, you also experience a lot of physical changes. So there's sleep deprivation, your routine is really different, food tastes gross, you're more uncomfortable than you were before. There's a lot of stress and worry about what's going to happen next. On top of this, there are significant social pressures. So there are financial changes. You know, maybe you're going to have a partner who's not working or working less, or who knows what's happening in terms of someone's parental benefits that are there. I cannot tell you how many people choose to move during pregnancy or right around the time of delivery. So people suddenly say, wow, you know, we need more space. There's going to be a baby here. And then enter into the stressful world of finding a new place to live and the financial aspects that go along with that. People worry about work, they worry about transitions. So there's a lot that's going on during this pregnancy year. And it's really normal and part of the human experience to go through lots and ups and downs when you're going through a big event like this. However, sometimes it becomes more and we start to worry, is this something that's impacting you in a negative way? Is there a pathology here? Is this more than the normal ups and downs of a huge life event that you're experiencing? So I'm going to talk a little bit about what this might look like coming to a pregnancy appointment. So imagine you have someone, they're 32, never been pregnant before, they're coming to their first appointment, don't really know what to expect, had a bit of a rough first trimester with lots of vomiting and feeling nauseated and not sure when to tell coworkers about when they were pregnant. They have a supportive partner, but that partner is also concerned about things. You know, what's it going to be like to be a new parent? There's going to be financial changes that are real. They're looking to move out of their condo and sort of shopping for a bigger place and feeling all the stresses that go along with that. This person has a history of depression during university, so very common, you know, during especially big changes in life that someone might experience this. It lasted a short period of time and was treated by their family doctor at that point, and they're doing well since that, since their university years. They're feeling overall excited, but a little bit nervous. So this is a very normal experience that a lot of people have entering into pregnancy. So I see this person at their next visit, and they say to me that in the past couple of weeks, they cannot sleep. So they were able to fall asleep at night, but then when they wake up in the middle of the night, their brain is just sort of spinning and they can't stop worrying about certain things. Sometimes they're worrying about, is the baby okay? Sometimes they're worrying about, you know, what's going to happen next. And they kind of can't stop thinking about it. And then they start Googling it a lot and keep sort of researching it and trying to look into what they can do to try to prevent this, or what sort of bad things might happen that they might be able to prepare for, or how could they know what's going to happen next. She's finding she can't focus at work, having troubles making decisions on projects that she was previously able to make decisions about, feeling really teary, finding that she's crying at work. She's feeling super annoyed at her partner about things that were not previously irritating, and feeling super annoyed at her coworkers. Then her friends ask her out to have coffee and chat, and she doesn't want to go. She's worried that they might want to talk about the baby, or all the happy things that are happening, and she doesn't really know how to interact in that environment. And the big take-home message that I'm hearing from this conversation is she does not feel like herself. So this is feeling something beyond the normal ups and downs of riding out changes in life, but feeling really overwhelmed and not like herself. So phrases that people say to me, or you might be, have heard yourself, or maybe have a family member or a friend who said some of these things. People say, I just can't stop worrying. I can't stop Googling, I'm searching for things all the time. Something was mentioned on the ultrasound and I've been Googling this word over and over again, even though my doctor told me that this is something that I don't need to be concerned about at this point in time. Changes in eating that's beyond just the normal nausea and vomiting and food aversion that's there. So feeling like it's something more than that. The waking up at night with worries and your head spinning, inability to focus on things that you used to be able to focus on, a sense of hopelessness or helplessness about the future. Physical symptoms. So some people have like chest tightness or palpitations, and it's important that, we take these things into consideration as there's some medical underlying concern when someone's presenting with those symptoms. But, after exploring it, is there something else that this is more of a response to an anxiety concern the person has? And then this inability to focus and make decisions on things they used to be able to do. So part of those prenatal conversations and in the antenatal visits is I'm hoping that we can find out, are there risk factors? Is there a history that's there? And so we talk about anxiety and depression. We talk about a history of eating disorders. Is there a history of abuse or assault? Is the person safe in their home? Do they have certain worries about coming into clinic? What is support like at home? Are there other stressors that are going on in that person's life? So after having this conversation, I say, I'm worried that you're having some anxiety or depression or both, and I recommend a referral to our Women's Mood and Anxiety Clinic. So why do we need to identify this and treat it? And a big take-home message is that when we're talking about treatment, we're not talking about treatment versus no treatment. We're looking at something bigger than that. And this is a big balance of risk and benefit overall. So the things that we're balancing is on the, what are the risks of treatment? So it takes time and resources, and you have to find time for self-care and time for sleep. Attending a group class, seeing your psychiatrist and following up. That, putting yourself out there, maybe needing to ask for support for families and from family and friends, talking about the possibility of using medications and side effects and risks that might go along with that. But what you're really balancing that with are real risks to the pregnant person, real risks to the newborn, and risks to the parent-child interaction. So that's actually what we're comparing when you're talking about treatment versus no treatment. So the risks that we're talking about are real for both the person who's pregnant and the fetus, so when they're still pregnant and after birth as well. So the way that anxiety and depression can impact that pregnant person, one of the big ones is limited engagement in medical care and self-care. So this is someone who maybe has an important medical appointment and they miss it, maybe stops taking a medication that they need, maybe is finding that they're not able to eat the nutritious food that they need to eat, changes in weight gain, changes in sleep habits. There's an increased risk of substance use. So this could be smoking, this could be marijuana, this can be alcohol, this could be other drugs. There is an increased risk of preeclampsia in the untreated population of people with anxiety and depression during pregnancy. So that's a pregnancy-specific concern associated with high blood pressure and other physical changes. When you have anxiety and depression during pregnancy and it's not treated, you're more likely to have postpartum depression. So it's more likely to continue onwards. So that's a really important one to think about. And also a higher risk of baby blues, which I'll talk about a little bit more in a moment. It can also be associated with a disrupted relationship with the partner. And so that can be an important source of support for some people. For some people, it's not, and actually, can be feeding into the anxiety and depression. But it is associated with those concerns. And then, of course, as we heard about already, there is a real risk of suicide and self-harm. It also can impact your baby. So we know that for people who have untreated depression and anxiety during pregnancy, people are more likely to have a preterm baby, so a baby born before the time frame that they're safer to be outside in the world, more likely to have a low birth weight baby, so a smaller baby. And both of these things can have long-term consequences for that child. And it can also be associated with an impaired infant attachment in the future. Importantly, during pregnancy, some people worry about being on medications or taking certain treatments or therapies, and choose to stop taking them during the pregnancy timeframe. And there might be a thought, oh, pregnancy is protective. I'm going to be so happy when I'm pregnant that I'm not going to need this to keep me healthy. However, we do know that people who stop their treatment during pregnancy have a greater risk of relapse. So this would not be something that you would want to do lightly and without talking to the person who is caring for you about your depression, anxiety, about whether or not that's a good idea to do in your situation. I'm going to talk a little bit about baby blues versus postpartum depression. So baby blues is very, very common. And as we heard, 50 to 80% of people experience some degree of this. It is different than postpartum depression, but the symptoms are similar. So people might feel withdrawn, they might feel quite teary, they might feel angry. This usually happens shortly after birth and doesn't usually last longer than 2 weeks. So that's a big piece of saying, is this postpartum depression or is this baby blues? Also with the baby blues, most people feel, although they're experiencing these symptoms, they're still able to care for their baby to some degree. So there's still some coping that's there. I think it makes sense why people have the baby blues. When you think about it, you have someone who has just been awake for 1 to 3 days and done the equivalent of running a marathon or having a major abdominal surgery or both at that time. Then they're having major hormonal changes that are there. They're handed a new baby that they now need to feed every 2 to 3 hours. They are maybe having pain, they're exhausted. They're also at the same time maybe super happy and having some joyful experiences that are there, flooded for some people with feelings of love at the same time, or feelings of fear or feeling overwhelmed. So it's a big time. And then on top of that are family expectations. So you've been through this big change and then everyone says, oh, come, I'm going to come to your place and, you can kind of host me and I'll be your guest, or, you're supposed to be happy all of the time. And so it can be a really hard time for a lot of people. The way that you treat the baby blues is with support and rest. So these are the real tenets of support through the baby blues timeframe. Postpartum depression anxiety is very similar in presentation to depression anxiety during pregnancy. However, it can be compounded by the sense that you're now more stuck in that you have this small baby that you're with and you're in a healing and recovering timeframe. The sleep deprivation is severe. And there's a lot of real worries surrounding the well-being of the baby. The baby does need to be taken care of, and there's a lot of real worries and needs that are there. It is harder when you're in this scenario to maybe get out and access support, see people who might be your support system, or access help from a medical perspective. One of the things that makes this really hard are motherhood myths. And I wanted to put this in here because I think that this is a real barrier to accessing care. So there are myths that are out there that once you become a mother, you will have complete joy and fulfillment. And that's what's supposed to happen as soon as that baby is placed in your arms. Motherhood is easy. You will naturally know what to do. Being a mother always means sacrificing your own needs. So if you have a need and you want to fulfill that, be it sleep, be it exercise, be it socialization, you shouldn't be doing that. There's something intrinsically wrong with that. You should always be sacrificing for your baby. And breastfeeding is natural and therefore it's easy to do, right? So these are all myths. The problem with these myths and the problem with them really being perpetrated is that people have a sense of shame when they feel otherwise. So you can have this sense that, oh, I'm not good enough. I'm having these feelings and it's not what I'm supposed to be feeling. And it can delay in asking for and receiving help. So it's important to really talk about the myths surrounding motherhood. The impact of untreated depression, anxiety in the postpartum period, it can really impact that person ongoing. So, significant impact on quality of life for that individual. It can change sleeping, eating, self-care. So all those same things we talked about for the antenatal timeframe. And there is that ongoing risk of suicide and self-harm that we discussed. It also impacts the infant because it can change the way that people interact with their newborn baby. So people who have untreated depression, anxiety in the postpartum timeframe are more likely to have babies that have delays in physical and mental development, and that can include cognitive development as well as language development skills. And there's overall an increase in health concerns for that infant. It can impact that interaction as well. So it can change breastfeeding, so to have reduced amounts of breastfeeding, and impact the bonding experience. So I'm just going to go back to our patient. So we referred them to the Women's Health and Anxiety team, and she was treated for depression and anxiety. And she said she started to feel more like herself. She was able to enjoy planning for her new baby. She still had some tearful days, but it was less so than before, and her sleep was improved. She gave birth to a healthy baby, and she continued to follow up with the team for the next 3 months, after which she felt, although she was tired, she was adjusting to parentage. So I'm going to talk just briefly about a couple of groups that are at increased risk or may have some special concerns or needs surrounding mental health. So one of them is a group of people who may have had a birth trauma. So this means someone who may have had an emergency happen at the time of a previous birth. They may have had a very prolonged or painful recovery, a baby in the NICU, so some really fearful events that are happening at that time, or a stillbirth or a neonatal death. In this group, there can be an increased risk of anxiety and depression in a subsequent pregnancy. Some people have PTSD from their previous trauma. And there's a lot of triggers that can happen when people come in for care. So that means they come into an exam room and they have this sense of dread, or going into an office, or ultrasound is a big one. So, they may have the ultrasound probe put on, and that was when they found out their baby's heart had stopped beating, and they're sort of reliving this, and it's very traumatic for them. So for this group of people, when we're planning what's going to happen during that birth, we really take it from a place of compassion, education, and autonomy. So letting that person drive what they need to have good mental health during the pregnancy, birth, and afterwards. And there's no one-size-fits-all approach to that. So it's a very personalized approach. I see a lot of people who are part of the subsequent pregnancy program, and this is specifically for people who have had a stillbirth or a neonatal death. And the type of care that we try to wrap this person who's had this experience in is medical investigation and monitoring, so we know what's going on. We do a lot of interdisciplinary care with psychiatry, of course. We do very frequent prenatal appointments. People tend to be paired as well with an advanced practice nurse who can provide some increased communication, so people always feel like they know what's going on. Again, birth planning with a focus on autonomy and support about what's going to happen during that birth. And we have some community supports as well, for example, through the PALE network, that there's a link through the Sunnybrook webpage on how to access that. Another group that there can be some concerns about depression and anxiety are people with disabilities. We know that prior to pregnancy, people with physical disabilities have higher rates of depression and anxiety. We see it more during pregnancy and postpartum. The concern within this group is there is a real fear of judgment and bias. And so this can also cause a delay in people seeking help because of this ongoing worry about bias. For this group of people, attending prenatal appointments can be more stressful. There can be transportation concerns, timing concerns, and people with physical disabilities are more likely to experience more pain during pregnancy, and also then changes in mobility, which really changes that person's sense of self in terms of how their function is changing during pregnancy. So we see a lot of people through the Accessible Care Pregnancy Program. And this includes, of course, medical management of that person, so they're feeling well cared for. It's a very supportive environment, interdisciplinary environment. We try to encourage people to meet with lactation consultants early on, to have a breastfeeding plan early on that is suitable for that person, because we want people to go in feeling confident and that they have an individualized care plan and not worrying about those sense of failures surrounding breastfeeding, or maybe it's an inappropriate breastfeeding plan for that person. Pain management is a big piece of it as well. And then, of course, corresponding with psychiatry for people who need it. We also work with community resources such as the Center for Independent Living Toronto, which has a parenting for people with disability group. So there's a lot of peer support that's there too. So the take-home message is that anxiety and depression during pregnancy and after birth, it can happen to anybody, but there are some people who may be more at risk. We know that untreated depression and anxiety can be harmful for both the person who gives birth and to their baby. We want you to talk to your healthcare professional if you have a history of depression or anxiety, or if you have symptoms that you're worried about, and that depression and anxiety are treatable. So talk to us about it. All right. Thank you so much.
Thank you, Dr. Burndell. That concludes our formal presentations. We'll now begin the question and answer portion of the evening. And if you'd like to submit a question, you still have an opportunity to do that. I'm going to moderate the questions and ask our panelists to help answer some of these. Okay, I'm going to start with a question. If you're on anxiety and or medication for depression, if you're on medication for anxiety and or depression and thinking about pregnancy, what should your first step be? Sophie, do you want to take this one?
Yes, thank you. That's an excellent question, very common. I would suggest you go speak to your healthcare provider, and maybe you can come up with a plan that would be, the most suited to you. But certainly talk to people that are knowledgeable. Don't rely on Dr. Google, because Dr. Google is not going to individualize it for yourself, but healthcare providers that you trust.
I would also I would say, just as on the obstetric side, and maybe Anne, if you have anything to add here too, is, some people are on treatment, taking medications for anxiety and or depression, and find themselves to be pregnant. And so that's okay too. We're not getting really into the specifics of medication therapy tonight, but I would say the majority of medications that are prescribed are considered to be safe in pregnancy. And so that would be something to see your doctor early, or your midwife or family, whoever's looking after you and providing you with pregnancy care, to just have that early appointment and review. We definitely don't recommend people stopping their treatment or their therapy all of a sudden in the early stages of pregnancy. I don't know if Dr. Burndell, Dr. Gregoriadis want to add anything to that.
I think that you said it very, very well. Don't stop things right away. Go see someone, preferably the person who's caring for you and prescribing those medications for you, who knows you, and you can talk about where you're at, and if there's any concerns or any changes that need to be made, or if, continuing onward with exactly the schedule on is the correct one, or if there needs to be any modifications, but they're the right person to talk to.
I totally agree. The very important point that Dr. Bodley made is that stopping your medication abruptly is something that can have lasting effects for yourself. So you really, it's best not to do that if possible. And then if you can, right, making a plan for whichever direction you want to get to is totally appropriate. We see people all the time in various stages, treated before they get to us, or untreated before they get to us. And we kind of go with what works for them. But it's very important not to stop abruptly. I agree.
And I think maybe just to follow up on that, one of the other questions that I think is really relevant to this discussion is, are antidepressants and other medications, if needed, are they safe to take while breastfeeding? Sophie, I'll direct that one to you to start.
Absolutely. So there are a number of different antidepressants as well as anti-anxiety medications. The majority of them, very low amounts, get into the breast milk. But again, talk to your healthcare provider to make you feel comfortable with whichever direction you're going. They could give you information on what we know. And this is an area that's evolving very quickly now, it seems. More and more information is being published on the rates and in this area in general. So we know more and more as we go, but it's very important to ask. But yes, it's very possible to breastfeed while you're on medication.
Thanks, Sophie. Is there another question here? So someone's asking, what is the best window of time, I think, or time in pregnancy to start getting treatment for it to be effective? So is that, maybe a little bit related to how long might someone need to be undergoing some treatment and therapy in order to see the results of that? Is there kind of a guesstimate? I think it probably depends case by case a little bit, but what would you say?
If I can answer that. So yes, of course, it depends case by case, but I think maybe what the person might be getting to is what we know from the general literature. In terms of the general adult literature, we know that the longer somebody is depressed and they don't seek treatment, the harder it is to get them treated. So if that's what you're referring to, yes, if it goes on in pregnancy and postpartum, it might be more challenging to feel better. But anytime you go for treatment is the right time, right? So as soon as you can go for treatment, please do, because we have good treatments and they can be very effective and life altering.
Mm-hmm. And to follow that, one of the things that I encourage people is, if I've identified that I'm worried someone is at risk of anxiety and depression from seeing them during pregnancy, I do encourage them to accept a referral as soon as possible. So, sometimes people say, "Oh, I'll see if I'm, if it's been a while," and I'm like, "No, I'm worried enough that I want to refer you." So they'll say, "Oh, maybe I'll wait and see how I do over the next little bit." But I do encourage people to say, why don't we get the ball rolling? Let's get that started, because the worry, of course, is that things will worsen and we'll end up in a crisis situation if we didn't try to intervene as soon as possible. So, that timely intervention is really important.
And remember, on one of the slides, I talked about prevention and I talked about counseling. So the earlier, if you have a history of depression and anxiety, the earlier that you can connect with someone that can help and address a lot of the stressors that you may have, we know that that's very effective. So the earlier you can get help, I think, the better. But any time is good.
Yes, and I think it's really important. I think one of the reasons we're also here and talking about this is really to break down concerns about stigma and challenges of people actually feeling comfortable talking about their mental health, whether, at any time, but especially pregnancy and postpartum. And I think one of the other things I would highlight is both Dr. Burndell and Dr. Gregoriadis were talking about, there's, I think we have this belief that they're going to just give me a medication. And, a lot of patients people are reluctant, and that's fine. Not everybody wants to take medication. It's really important. And I think we've heard that from this talk, that there are so many other modalities for treatment, and, there's so much power in the education piece and the counseling and sort of knowing that you're not alone, and also how to be very proactive in this area, I think is super important. I think the other thing I would say is, when someone needs a referral, unfortunately, just based on how things are in the system, it can take some time to get an appointment. So we also want to make sure, as Dr. Burndell said, we're on top of this, right? And we're not waiting until that last minute when, yes, we can get urgent things done, but it's always better for both patients and support people to be able to kind of bring people to care as soon as possible. I don't know if that makes sense.
If I can just add to that, because we recognize in the clinic that it's very important to get timely treatment, unfortunately, we limit how long we can follow people so that we can see as many new people as possible. So we follow people for about up to a year postpartum, and we try to see them within a few weeks after referral, and sometimes it's a little bit more or less depending on staffing and other issues. But it's because of that we cut off follow-up in our clinic to about a year postpartum, so that we are more available.
Great.
And one of the things that I've noticed as well is sometimes if someone isn't feeling quite ready to accept a new referral, in terms of after identifying a concern, is sometimes they'll say, I have a good relationship with my family doctor. I've spoken with them about this in the past, and I'll encourage them to go and see that person. Or, a few years ago, I saw a counselor for this other reason, and I felt I had a good relationship, and I think I can get in contact with them. So even if they're not ready for that, or they're worried about the waiting for that referral, in terms of that time frame, and that we're always working as hard to keep as tight as possible. Other resources, other social supports are really important, and so encouraging those is really important too.
Absolutely. And we appreciate that many people don't want to take any kind of medication in pregnancy. And that's one of the reasons why we're investigating non-drug alternatives, whether it's psychotherapy or stimulation treatments. We're trying to work on that.
Mm-hmm. So slightly different kind of question here. Looking back, I'm pretty sure I had anxiety after my first child was born. Though at the time I thought it was just normal worry because she wasn't feeding well. Now I wonder if my own anxiety could have contributed to her own. Is that a common risk if the anxiety is not treated early on? Sophie, any ideas? Does parental anxiety that's not treated increase the risk of anxiety in our children?
Right. So again, we're not talking about any one individual person here.
Absolutely.
All risks and benefits are individual. But if you recall, Dr. Burndell did put up a slide earlier that highlighted that there can be consequences for the baby later on. So there are associations, with fussier babies or harder to soothe babies, and later on with depression and anxiety. But you also have to appreciate that those research studies were done with, various cohorts, and we don't know how sick those mothers were, right? So there's a wide gamut between being anxious to being totally handicapped with the anxiety and requiring hospitalization. So we don't know in terms of the severity the effect of that, but it makes sense to think that the more severe, right, the more there would be longer-term consequences. So for example, if the person was severely depressed and they weren't taking care of the baby as much as other healthcare, or as much as other people were, so that there's some neglect perhaps for the child, or some other issues, then it makes sense to think that there would be some consequences of that. Okay, so it's very, I guess, convoluted. It would be a nice word. It's not straightforward.
Yes, I think that makes it somewhat challenging to be able to give very specific numbers or answers. Along those lines, the questions come in. What is the success rate when people are treated for anxiety and depression in the perinatal period or postpartum period? Do most people recover if they get the kind of help that we're talking about?
Yes. So excellent question. Are you asking me this, Janet?
I think you could start. I think this would definitely be your area of expertise.
All right. So let me start with that. So we look at research studies to see, what are the rates of response for antidepressants? What are the rates of response for various psychotherapies? What are the rates of response for psychoeducation? And it really varies. It depends on the kind of treatment. It depends on the treatment provider. And then we also know that the population that was treated is also important too. Where are they from? What obstacles are they facing on a regular basis? So there are a number of different variables, but all in all, and it also depends on the clinic that you're talking about. So there's research on the one hand with the multiple variables, and there's also the women that we see. I can tell you with confidence that the majority of the people that we see get better. They respond to treatment, okay? But if you look at the absolute numbers in research, so what are the effects for medication? Anywhere between 50 to 80%, depending on the study that you look at. What are the effects for talk therapies? Anywhere between 50 to, again, 80%. It really depends on the number of factors that I already talked about. But the point that we were all trying to make is that treatment is effective and it's worth pursuing, and not to let yourself suffer during this time. It's hard enough as it is.
One of the things that I see on my end, because I'm not the one providing this treatment, but I do see people when they come back for their next pregnancies, and I have to tell you how grateful they are for the care that you and your team have provided, and are interested usually from the get-go in participating again and getting referred again, because they felt night and day from after they were able to see you and your team and get treatment. So the message that I try to tell people is this is a treatable condition. There is help for you, and people who go through it do come back saying, you know what, I think I would like to proactively ask for that help again, or just get involved, or just touch base. And I think people feel empowered knowing that it is something that they can tackle. They have a toolkit available, and they know they have support people that are there, and they want to do it again. So to have that support that's there, so it is appreciated.
Sophie, I'm going to direct this one at you, because I think it relates to some of the information you were providing about some of the research, some of the non-invasive, non-medicine treatments that are available, or some of the research trials that are out there. How would a patient find those resources or access? I know we had the Sunnybrook website up earlier. I think a lot of those links are in there.
Yes. So for the research in particular, you can find us on the Sunnybrook website. So it would be under, you could actually just do Sunnybrook Psychiatry Pregnancy, it'll pop up. So we have an outline of the kinds of studies that we're working on right now. And the TDCS one that I talked about is also there. If you want to talk to a research associate that can tell you more about the studies in person, you could email WMA, so Women's Mental Health, at sunnybrook.ca, and you'll get a response. WMA at sunnybrook.ca.
Great. And if somebody is concerned that they are exhibiting signs and symptoms, for example, of postpartum depression, and perhaps have some concerns that their family doctor, for example, isn't particularly comfortable talking about or treating patients in this area, do you have some suggestions of how people can access these resources, or ways to have access without necessarily working directly with their family doctor in those more rare situations, or maybe not that rare, but how can people access this? Or, for example, I think one of the big things we're seeing right now is just patients who don't have family doctors. Are there ways to get into clinic, or what do we need to do?
And do you want to tackle that one?
Yeah. So, I mean, one of the things that I'll usually bring up, just in terms of my general screening, when I see people during pregnancy, but then in the postpartum timeframe, if I'm concerned and they say, you know what, I don't think I'm ready for a referral right now, and I said my standard things about other resources, I say to them, you can call me later. So if you I have notes from this conversation. You know what I mean? Like it's all there. And if you go home and a month from now, you're unhappy, you're worried, you're not getting the support you need, you think, actually, I really need to get integrated into that system, they can contact me, and I'm happy to put that referral in still for them. So I let people know that if they don't have another access point, that I'm still there for them to help get those resources organized for them in the postpartum period, even sort of in that time frame after. I'd still be seeing them as an obstetrician, you know, following their pregnancy care. I can still help be a link for them to the resources they need. So that's something that I can do, you know, and I don't know, you know, for people who maybe aren't at Sunnybrook or, you know, aren't at other locations, what their pathway would be. You know, I also often will talk about how to find a psychologist if they, you know, otherwise, in terms of using resources like Psychology Today, you know, how to find someone who is a registered psychologist that, you know, suits their needs or takes their insurance and, you know, is in their area. So I try to also talk about other resources that may be appropriate and available for that person.
A good resource is called Bounce Back. That's a program that's available to everybody in Ontario. You don't need referral. So if you just look up Bounce Back, you can self-refer to get more information about mental health services and actual talk therapy, I believe.
Yes, and I would say that along the lines of what Dr. Burndell said, a call to your pregnancy, whoever was looking after you, whether it's a family doctor, midwife, obstetrician, a call to that person or that person's office and just mentioning you're concerned about postpartum depression or very bad blues or anxiety. And I think, as Dr. Burndell said, you know, my door is open if you realize a month from now. But what if you're a patient who this didn't come up before, and it is very much in that postpartum period? We do see our patients postpartum, but there is a gap often between the time you're discharged or you go home after having a baby and when you come back to see us. And so if you're really struggling in that time, I think the majority of us would take a phone call and help you access the care and the resources that you need. And just
Absolutely.
keeping that linkage in mind too. I think we're getting closer to the end of our questions. There's one more here. I don't know if you'll know this one, Sophie, but someone mentioned how certain groups are at higher risk of perinatal depression and anxiety. And are there any mental health programs that are aimed at helping those specific groups?
So the highest risk factor is a previous history of mood and anxiety problems. So the groups that we offer are generally for treatment. We don't have any prevention groups at this point, but that's because of resources. And off the top of my head, I don't think Mount Sinai has one, nor Women's College in terms of prevention. But once someone is in our program, we talk about the various groups that we have, and they don't necessarily have to be symptomatic to attend them.
Great. Thank you. Well, any last comments from our panelists? Anything you wanted to say? I think we're heading to the wrap-up time.
I just wanted to close by saying that I'm delighted to have been asked to talk about these issues, because as you said earlier, Janet, there's still so much stigma out there. And I love the slide that Dr. Burndell Ann presented earlier. This can happen to anyone. And it's very important, you know, to seek help, because you can have a different experience with some treatment.
And thank you so much again also for inviting me. I mean, I think that across the board of the types of people that I see during pregnancy, this is an underlying concern. So this really is universal. You know, and I see people from all walks of life, you know, with all different pregnancy experiences in the past, all different histories. And this keeps coming up. And this is something that's really important for us to know, I think, individually, but also as a society, about what happens during pregnancy and the postpartum timeframe. And so that we can talk about it more, be more prepared for it, and be able to support each other more through this time.
Absolutely. And I'm just going to point out this slide here again. So if you are going, you can click on departments. This is on the sunnybrook.ca public website, and you'll find the Department of Psychiatry, and there's many resources here that are very helpful. We recognize that we've talked about some really significant issues, and sometimes these bring up questions, concerns for people who would benefit from having some urgent resources or care available. So I just wanted to highlight that again for everybody. And as we're wrapping up, just a few more points before we actually close the webinar. Please be sure to take a moment to fill out the electronic evaluation form that will help us in planning future talks and topics for you. You can also add your name to our mailing list for future talks. I'd really once again like to thank our speakers for an incredibly informative evening. And thank you again to Ileana Ores Valiente from our board for providing her welcoming remarks. And a big thanks really to all of you for joining us for this educational event. Please be sure to check out our upcoming topics, which will be shared on the Speakers Series website. And have a wonderful evening. Thanks again for your attendance.